Greetings and welcome to this antibiotic series videos. In this video, we'll discuss about the tetracyclines. This is for physicians and practicing critical care consultants. We'll discuss about doxycycline, minocycline, and digicycline in detail through and through. If you're new to this channel, do subscribe. Let's get started. So, why tetracyclines matters in this era of high-end spectrum of beta-lactams, carbapenems? Why tetracycline do matter? Because it has a lot of clinical role in it, because the infections, zoonoses, and MDR organism in selected cases. It is a very broad spectrum of drug, which is a protein synthesis inhibitor, excellent tissue and intercellular penetration with a very low Clostridium difficile infection, especially doxycycline, which have very low Clostridium difficile risk. So hence this is a almost the highest preferred drug which covers the atypical infections. It has outdone the macrolides in all these adverse effects, which are very low in case of tetracyclines compared to macrolides, which is azithromycin and clarithromycin. So tigecycline is also one of the tetracycline used as a last resort drug. It is not a routine ICU therapy. We'll not discuss about tigecycline alone in this video. We'll go into this much later. So mechanism of action is binds to the 30S ribosomal subunit, blocks the tRNA synthesis, and it is a bacteriostatic drug. Remember, it is not the bactericidal drug. So hence, you should always combine it with a beta-lactam or an carbapenem drug when you are using it for in an ICU setup. In a case of sepsis, not in case of other infections such as atypical pneumonia, you can use it all alone. So it can develop resistance also in case with development of efflux pumps and ribosomal protections. So this basically binds to the 30S ribosomal subunit and blocks the tRNA attachment. So class-wide contraindications, there are only a very few contraindications for these tetracycline drugs, which is allergy as usual and history of idiopathic intracranial hypertension. Always remember a patient with hypertension not diagnosed, having recurrent hypertension, elderly male or elderly female having idiopathic intracranial hypertension, suspect, don't give tetracycline. It can absolutely exacerbate the risk. Severe liver failure is again a relative contraindication. Myasthenia gravis again a relative contraindication. Again, it is safer than macrolides and fluoroquinolone in this regard, but often preferred when atrial coverage is needed in myasthenia gravis patients. So again, this is a contraindication relative, but again safer than macrolides and fluoroquinolones. So drug-specific contraindications are doxycycline, where especially it can cause esophagitis. So hence, drink with at least 150 to 200 ml of water can cause esophageal stricture all alone. It can cause esophageal stricture when the capsule gets broken down and injures the esophageal surface. It can cause stricture. If in case of history of lupus, it can cause exacerbation risk. So for minocycline, again, autoimmune diseases can be exacerbated. Drug-induced lupus risk is there, and hepatitis risk is there. Digicycline, class-wise contraindication only, not otherwise much contraindication. The drug interactions, again, it chelates with the cations such as aluminum, magnesium, calcium, iron, and zinc. So, and again, avoid cholestyramine when you give doxycycline drug. So, ensure these electrolytes are normalized, especially calcium, magnesium, when you are giving a doxycycline drug. So, it is a cytochrome induces, so it decreases the half-life of barbiturates, carbamazepine, and phenytoin. So in case of a seizure risk, try to avoid doxycycline. It can exacerbate the seizure risk. Also, in case of idiopathic intracranial hypertension, try to avoid doxycycline. Increases calcineurin and mTOR inhibitors. So isotretinoin, also it can increase intracranial pressure risk. So when you remember these drugs, if in the drug chart, don't give doxycycline. Interactions for minocycline, digicycline, same absorption interactions as doxycycline. In case of isotretinoin, there is a high risk of pseudotraumatic cerebri, hence not given with minocycline. Digicycline, again, very few interactions with PGP substrate inhibitors and may increase calcineurin inhibitors levels. Otherwise, not much of an interaction. It's very much safer drug compared to macrolides and fluoroquinolones. Side effects, again, we have discussed about the GI irritation, nausea, vomiting, esophageal ulceration can lead to stricture, and pancreatitis is a very rare complication of doxycycline. Photosensitivity, IV pill bite is in case of IV injection. So most of the injections you give doxycycline through intravenous route, and the patient will have severe pain. So hence dilute with a good amount of fluid and give it IV. A lot of patients complains of pain when you give doxycycline through IV route. Steven Johnson syndrome, lupus exacerbation with pericarditis especially can be caused by doxycycline. Minocycline, prominent CSS sinus side effects such as vertigo, dizziness, confusion, sudden tumor cerebri are very, very common. Plus the standard GI photosensitivity. This specific side effect of minocycline is that it can induce drug-induced lupus and the autoimmune hepatitis. So autoimmune conditions has always has the history before giving a tetracycline drug, especially minocycline. Recycling again, nausea, vomiting, pancreatitis, hypoglycemia are common. Otherwise, hepatitis, drug-induced liver injury, coagulopathy, phlebitis are also common. Anaphylactic reactions, pseudotumor cerebri, photosensitivity also can occur. So, slow infusion rates can reduce nausea. So, why physicians love Doxy? So, as a physician, I even love Doxy. It's because of its very good safety profile, low closed difficile risk, and minimal resistance selection and hepatic clearance. Works in even augmented renal clearance patients. So, very good tissue penetration, and so the only problem is the poor serum reliability. So, avoid in bacteremia and endocarditis. For these conditions, don't go for doxycycline as a first line. It has a very good tissue penetration. Whether it is a lung infection, it is for atypical pneumonia. It's very good drug. For intracellular organisms, it can be a very good drug. Doxycycline for currently it's mainly used for atypical pneumonia has been mostly used rather than a macrolide drug. For zoonotic infections such as Rocky Mountain spotted fever, anaplasmosis, Ehrlichiosis, and these are the drug of choice. Doxycycline is a drug of choice. Community acquired MRSA skin infections, again doxycycline is preferred. So cystitis, high urine levels are there, so it can be used for cystitis if the organism is sensitive. Only limitation over lung doxycycline is that babesiosis is not covered. So babesiosis is a parasite infection which is not covered with doxycycline. Spectrum is again MRSA, more than 85% is susceptible. Go for skin and soft tissue infection of MRSA, you can go for doxycycline, and then definitely not for bacteremia. MRSA bacteremia, don't go for doxycycline. In that cases, vancomycin is the drug of choice. Streptococci resistance is rising, but currently Streptococci is also susceptible to doxycycline. Streptococcus pneumonia, almost 20% is resistant, otherwise 80% is susceptible. Gram negative only 3. Don't go for all the enterobacteria. Enterobacteria are not covered by doxycycline spectrum. Only E. coli, that too very specific, some E. coli are covered. Otherwise, Moraxella and H. influenza is covered. It mainly covers the atypical organisms such as Mycoplasma, Chlamydia, Legionella, Listeria, and Bacteria fragilis. It does not cover babesiosis. So zoonotic, it covers nearly all zoonoses except for babesiosis. So Coxiella, Yersinia pestis, Chlamydia psittaci, Bacillus anthrax, leptospirosis. Leptospirosis drug of choice is either ceftriaxone or doxycycline for given for up to 7 to 10 days. For Pasteurella, for brucellosis, doxycycline is a drug of choice. Francisella tularemia tularensis, again doxycycline is a drug of choice. Plaque, doxycycline. Psittacosis, doxycycline. Coxiella gypnetic Q fever, it's again doxycycline. So for all zoonotic coverage, it is unless proven otherwise, it's doxycycline except for babesiosis. Minocycline, how it differs from doxycycline is that it's more lipophilic than doxycycline. It has a better CNS penetration than doxycycline. Because of the better CNS penetration, it also have more CNS side effects such as vertigo, low seizure threshold, everything, and idiopathic intracranial hypertension risk because of the better CNS penetration. It's more potent than MRSA and reliable Acinetobacter activity. It is less reliable with a streptococci compared to doxycycline. Clinical uses nowadays very select clinical use of minocycline because of autoimmune toxicity and other side effects more than doxycycline. It's currently nowadays not much preferred. So very rare cases we can use it for MRSA, Acinetobacter infection, and for CNS infection. There is some theoretical advantage not used practically these days. Used cautiously due to autoimmune toxicity, drug-induced loop, and autoimmune hepatitis risk. Dicycline is in only two major problems with that. It is very low serum levels, very poor drug for bacteremia. Whenever the organism, even if it is reported as dicycline sensitive, never go for this drug in case of a bacteremia because of very slow serum levels. It has a massive volume of distribution, so it's a very long half-life with slow loading. So it explains the higher mortality signals in studies. So even my ICU consultant does not prefer the tigecycline drug for even a susceptible infection and go for some other drug, probably a ticoplanin or uh, other group of drugs rather than going for a tigecycline. Tigecycline went for extremely drug-resistant organism for MDR salvage therapy only, not for routine ICU surges. For pneumonia, skin soft tissue infection, complicated intra-abdominal infections, and possible adjunct in fulminant Clostridium difficile. Only remember these four use cases for tigecycline. That too, even after considering all the other group of drugs, you can go for tigecycline. It is for every MDR organism and response only to tigecycline. Spectrum, it covers all gram-positive cocci, MRSA, and vancomycin-resistant enterococci also, ESBL, E. coli, Klebsiella, carbapenem-resistant Acinetobacter, anaerobes including Clostridium difficile, Listeria, and Mycoplasma, and Chlamydia. Okay, so even though it covers all these organisms, its pharmacokinetics and dynamics makes it not a good drug for use in case of a bacteremia. So it misses the Pseudomonas completely, Proteus, Providentia, and some Morganella species. It misses all the 3Ps and M. 3PM, it misses Tigecycline. Covers most of the Enterobacteriaceae, all gram-positive cocci, carbapenem-resistant Acinetobacter, anaerobes also, Listeria, Mycoplasma, and Chlamydia also. So, dosing of doxycycline, it is based on the syndromes we usually dose. Loading dose is always recommended. So, most people, most hospitals, or most physician does not follow this loading dose method for doxycycline. It is always recommended to give a 200 milligram loading dose or 200 milligram Q 12 hourly, that is twice day for 3 doses. Then go for maintenance dose of 100 milligram Q 12 hourly, per oral or IV. So this is the recommended standard regimen for doxycycline. Don't go just like that for 100 milligram BD. It's not the use case. It's always 200 milligram stat followed by 100 milligram BD. Not 200 milligram 3 doses, then followed by 100 milligram BD. So meningitis, it is 200 milligram Q 12 hourly. Again for Legionella, it's again 200 milligram Q 12 hourly for 72 hours. Then 100 milligram for 100 milligram Q 12 hourly. Renal adjustment, there is no adjustment required. For ECMO, there is limited data, likely adequate. You can go for doxycycline. So its absorption is decreased by cations. It competes with aluminum, zinc, iron, all of that, and milk also. When taken with milk, it is decreased absorption. Minocycline, it is again 200 milligram loading dose, then 100 milligram Q 12 hourly. There is no renal adjustment required. In case of severe hepatic failure, it is 100 milligram Q 24 hours, always once a day. Doxycycline 100 milligram loading is the standard, then 50 milligram Q 12 hourly. In case of septic shock, 200 milligram load, then 100 milligram Q 12 hourly. For high dose for MDR and vancomycin resistant enterococci, you can go even up to 400 milligram loading, then 100 milligram 200 milligram per day. There's no renal adjustment. If then the case of childbirth C maintained by 50 less than 50 percentage, obviously consider 100 milligram Q 12 hourly. Always monitor CBC, INR, lipase, and LFTs every 2 days, every alternate day when you are going for digicycling. So again, digicycline is not so commonly used. In case you are using digicycline, then come to this slide and look for the loading dose and maintenance dose before giving an drug for that. Only for susceptible organism in specific sites, only the 4 indications that we have discussed and not for the others. So pharmacology, doxycycline is almost 75 to 95% bioavailable orally, whereas minocycline is almost 100% oral bioavailability. Protein binding is 82% with low volume of distribution around 0.75 liters per kg. Has minimum to moderate CNS penetration to 25%, half-life of around 22 hours, safe in renal failure. Again, CNS penetration is almost 50% in case of minocycline with 1.5 liters per kg, more lipophilic than doxycycline, and half-life of 15 to 17 hours, lesser compared to doxycycline. Doxycycline is given only IV drug, so it is a very poor blood and urine levels, not given for urinary tract infection, never given for urinary tract infection. CSF penetration is also very low, extensive tissue and intracellular penetration only. So it's given IV only with a volume of distribution of around 700 liters. So again, half-life of around 64 hours it can go, and elimination is completely hepatic, biliary 60%. Final take-home summary, tigecycline, again discussed, it's only for MDR salvage therapy only, not for bacteremia, never for bacteremia and urinary tract infection. Again, for minocycline, you can go for MRSA, Acinetobacter, and CNS penetration. Nowadays, its use case is now very less. So, doxycycline, the most used drug in this group tetracycline, used for atypical organisms, almost all zoonoses except for babesiosis, tick infection, Rocky Mountain spotted fever, Rickettsiosis, cryptyphus, leptospirosis, for everything, and MRSA, skin and soft tissue infection also, you can go for doxycycline. So, always remember to load doxy in severe infection and respect minocycline autoimmune toxicity and use it accordingly. This is completely taken from IDSA guidelines, Sanford guidelines, and up to date Kunha book for tetracycline usage. I hope you learned something in this video on tetracycline. We'll discuss more on these antibiotics in the upcoming videos. If you're new to this channel, do subscribe. Do this medicine beyond Harrison's. Together we make better physicians and better care to the world. Thank you for watching.